Future Pulse, investigating innovative cardiovascular research and the intersection of academic theory and clinical practice. I'm Dr. Thomas Nero, interventional cardiologist and director of cardiovascular research at CAFC. Hello, and welcome to Future Pulse. I'm Dr. Tom Nero. Today we're going to be talking about inflammation and cardiovascular disease with Dr. Nehal Mehta. Dr. Mehta is a cardiologist, researcher, and professor of medicine at the George Washington University School of Medicine, and an adjunct professor at the University of Pennsylvania. He served as the section chief of inflammation and cardiometabolic diseases at the NHLBI and was director of the cardiovascular imaging at the NHLBI. During that time, he completed several randomized trials on the impact of biological therapy on vascular diseases. In 2018, he was awarded the NIH Director Award for demonstrating that high-risk coronary plaque was improved following treatment of their inflammatory disease. Dr. Mehta has won numerous awards and has chaired guidelines committees on cardiovascular risk reduction in patients with chronic inflammation. I think this is going to be a very interesting and timely topic with the development of various immunological therapies geared towards cardiovascular disease, and I think you'll find this conversation interesting. Enjoy. So welcome, Nehal. I've really been looking forward to our conversation today. Clearly, inflammation and cardiovascular disease is a very, I hate to use this pun, but a very hot topic. So I am really looking forward to walking through this all with you today.
Thanks.
So you describe yourself as a cardio-rheumatologist. I think that really cardio-immunologist may be a better term. You've done so many different research studies on not just cardiovascular disease and vascular disease in general, inflammation, rheumatologic diseases involving different types of cholesterol, HDL, LDL. How did this all start for you?
Tom, thanks for having me. And I do think that it's so important that we get a good understanding that inflammation is at the cornerstone of most diseases of chronic aging. I'll tell you, the root of it all was seeing that back in 2006 in Philadelphia, there was a paucity of cardiovascular risk factors, but a ton of heart attack in patients with obesity coming through my clinic. So I started getting interested in what was it about the obesity and the obesity epidemic. And I started biopsying adipose tissue, and we found early on adipose inflammation. And so I got into this just by way of understanding that inflammation, sort of what I call immunohyperreactivity, really are at the cornerstone of driving obesity, insulin resistance. That was the first axis. And then we realized that we really could not recapitulate the model very well unless we had a chronic human inflammatory disease to study. And then I very luckily at Penn bumped into somebody who was studying psoriasis as a risk factor for heart disease. And then that really set the stage of skin inflammation, driving adipose inflammation, driving blood inflammation. So the root of the story came down to why were obese people having heart attacks when they had a paucity of cardiovascular risk factors.
So it's sort of interesting that you sort of ended up with cardio-rheumatology as a lot of your focus, at least as a model for research, since it's only been, I would say in the last 5 or 10 years that people have really been talking about rheumatologic diseases as being a risk factor for cardiovascular disease. And clearly it is. And as you said, we don't really have good models for it, not just in humans, but we don't really have good models for it in animals as well. When we stimulate vascular disease in the animal models, it's really a fake model. It's not really the same thing as what we experience as people.
Yeah, and it's interesting you bring that up because how we probed the initial adipose inflammation story just a step before that was I was involved with Garrett Fitzgerald, Dan Rader, and Murdoch Riley giving a series of LPS, lipopolysaccharide injections to healthy humans to elicit an inflammatory response. So that's how we turned to psoriasis. We said it's not a physiologic model to inflame. Similarly, in animal models, they're not great models to recapitulate the human diseases. So we're really left with using epidemiological observations to then back up into translational and preclinical understanding.
So before we get into some of the more nuanced issues with the different rheumatologic diseases and how you're looking at them, because each of them are going to be slightly different, do you want to just walk us through for a second what you see as the sort of the basics for the model for atherosclerotic disease as well as other chronic inflammatory disorders that involve the heart?
Yeah. So I think the biggest appreciation that I had was as a cardiology fellow, early understanding that you could not have athero without two things, injury and lipids. And so the cholesterol hypothesis was borne out pretty true with all the statin trials. But the inflammation that really started this process was endothelial damage. So the basics for atherosclerotic cardiovascular disease are lipids in excess will then deposit into tissues, elicit an inflammatory reaction from macrophages, foam cells. And what we appreciated was the critical role of the bone marrow myeloid cells in this process, namely the neutrophils. And that, to me, when Peter Libby and others had started bringing up the critical role of neutrophils in Paul's CRP axis, that's when I started realizing that the basics for atherosclerotic cardiovascular disease overlap directly with what I was studying in rheum and immunology. And in fact, the initiators of for example, psoriatic plaque actually had a lot to do with the initiators of atherosclerosis. So that therein lied, sort of the first question, which was, is this just a manifestation of one disease just in various tissue beds? And so that's what the next 10 years of work ensued to understand the different rheumatologic diseases that all drive various manifestations of cardiovascular diseases.
Do you think that the immune response actually may precede even the development of the plaque, and that it is part and parcel with the development of the plaque? I was talking to another researcher earlier this week about that there's some beds that just don't develop atherosclerotic disease. And a lot of it we were thinking, well, maybe this is a hemodynamic factor or flow issue, but there has to be something that allows those neutrophils to interact with the cell walls, and that it is actually a primary part of inflammation beginning the process and then having these secondary issues and then the heightened inflammatory response giving us a vicious cycle.
Yeah, and the tissue-based inflammation is what I think I learned over time after having left Penn and then going over to the NHLBI intramural program at the NIH and then learning that really the tissue-based inflammation is the key. It's the fact that you may have blood-borne inflammation, which is the immune cells that have made their way into the blood. But yes, the reason why certain beds are protected from athero or may not get it, there is a need for initiation to happen with injury and then subsequent damage. And I think that the tissue-based idea that we need to get to the tissue in order to get to the disease is what we are now understanding with the systemic inflammation piece. The blood is only representing one component of the inflamed system. Could be the skin, could be the gut, could be the gums, whatever it happens to be, that primary source of inflammation needs to be curbed. If not, this will, as you said, be a vicious cycle.
One of the problems that we tend to do in medicine is we tend to reduce everything and try to make it all one answer. And it seems like it is a very complex system here. When we're looking at the inflammatory response that you've been studying, there's the inflammasome, there's IL-6, there's IL-1 beta, there's IL-18, there's a ton of different cytokines. How do you like to look at this as a systems-based process? And what have you studied as far as trying to evaluate the process? And what do you think is going to be the way that we're going to be focusing in on this over the next few years?
It's interesting that you bring up the systems-based approach, Tom, because I think the biggest factor in tying all of this together was the fact that high amounts of comorbid disease predilection in psoriasis started becoming, it became pretty evident over the first 3 years of the large cohort study that liver disease was upregulated, anxiety, depression were upregulated, arthritis was upregulated, and this is all in a skin disease called psoriasis. So clearly, the idea of looking at this as one system, what we started doing was saying, well, let's understand first the plaque. Where's the source of inflammation? We characterized blood and tissue lipidomics and metabolomics of those plaques. Then we followed those into the blood, and then we did whole tissue phenotyping of the blood, which included flow cytometry as well as other means of access. And then we finally ended with a round of vascular phenotyping, which was aortic, femoral, coronary, and carotid. And what was very evident was when the system was inflamed, when the whole system, whether it be because the neutrophil lymphocyte ratio was up, the CRP was up, the glyca was up, or they had a psoriatic flare, their whole plaque just around all their bodies were red and beefy. The whole system demonstrated slowing of sugar handling, so they became insulin resistant. The system became constipated of lipids, so you became a walking body of ready to go cholesterol everywhere. And then the biggest one we were surprised at, there was a definite defined immune reaction that would accompany this with different cytokines. So let me go through that. If you think about the cytokines as being innate immune activation, so your body sees something like a bacteria, something with a cell wall, TLR4, TLR1 get activated, and that goes and stimulates the innate immune system. Those cytokines tend to be those related to TNF alpha, IL-6, and what we would call classically the IL-6 CRP pathway. What we appreciated was that there was a unique signature that we thought was driven by IL-12/23, which later became more specifically IL-23, and another signature driven by IL-17A and F. Those two families, if you will, the 23s and the 17s, and those species of cytokines drive most of the skin disease. So if you look at what it is that the cytokines do, each one brings a certain cell type to become more active. When you looked at, and then we got involved with folks at the NIH who involved themselves in lupus, involved themselves in rheumatoid arthritis, HIV disease, and we have a few other inflammatory diseases. And when we looked at that, their cytokines were different. There's an interferon signature in lupus that is absent in psoriasis. There's a B cell signature that is present in rheumatoid arthritis, absent in psoriasis. And so what this starts to really make you think about is this could be an overactive immune system because of the cytokines. Now, why are the cytokines overactive? That's, I think, in the genetics. So people will manifest their hyperinflammatory syndromes maybe as a vasculopath, have serial MIs. Sometimes they define themselves by inflammatory bowel disease, have relapsing bowel problems. Some people have psoriasis along with psoriatic arthritis. So the genes that are telling the cells by protein stimulation of cytokines, each of these inflammatory syndromes has a signature. We're nowhere near understanding that, Tom. We're just scratching the surface. Different types of inflammation. I mean, we're still at the textbook definitions of is it acute versus chronic, but we are well beyond that now.
When you're looking at other forms of disease that you can then create, so to speak, so poor diets, how is that then stimulating this immune response? And specifically, how does the visceral fat affect the immune response, and the adipose tissues being the crucible for creation of these inflammatory mediators?
Before we, move to the fat, I think that's a great question, Tom, because that is probably where the action all epicenters and kind of forms its massive deleterious effects on cardiometabolic disease. But I would say that the smoking and the tobacco and the poor diet, let's just say that all of the lifestyle things, you have poor sugar control because you're diabetic, all of those things do stimulate an immune reaction very specifically. And when you have an inflammatory disease like psoriasis, what ends up happening is you have exaggerated responses to those. So smoking, for example, may trigger an immune response in the lungs that is exaggerated in those with psoriasis. But the bigger one of diet, if you just take that for a moment, we learned over a very early period of our research program that if you feed a patient with psoriasis an egg, they will hold on to 10 to 15 milligrams of that cholesterol compared to an age and gender matched control. They don't dispose and handle cholesterol the same. So the immune response then also stimulated, then reduces that even more. So you have a maladaptive response of hanging on to more fat, more sugar, more carbohydrate. There's an epidemic of obesity in our country, which is even more of an epidemic in psoriasis. 65% of patients with psoriasis are obese. The immune response collects adipose tissue macrophages. You asked about the crucible, right? Why is this the epicenter, if you will? The adipose tissue macrophages are primed and ready to go so that when anything gets into the fat is not just a storage organ. The fat is very metabolically active. And so in particular, the visceral fat, what we learned was psoriatic flares increase the space of it or increase the volume of visceral fat. There's more adipose tissue macrophages. We've biopsied and proven that. And those adipose tissue macrophages, when pulled out, have a more aggressive phenotype for more atherosclerosis foam cell formation, as well as more insulin resistance. So it sounds like these patients with psoriasis should therefore then be predisposed to stroke, heart attack, diabetes, and they are. And so this is where the critical role of then understanding how BMI or waist to hip ratio fits into all patients with chronic inflammatory diseases. If you're not looking at that, you're probably missing a risk factor. But again, going back just a few minutes to our conversation about different types of inflammation, patients with rheumatoid arthritis and lupus tend not to be obese. So clearly their cytokine profile is not one that's driving adipose tissue macrophages and visceral adiposity expansion.
On a side note of this issue of inflammation and diabetes and coronary disease, the patients who have elevated levels of inflammation for whatever reason have, I believe that from various trials, they said a 40% increased risk of developing diabetes over the course of the next 5 years, right? So what is driving that? Is it the initial inflammation part that's driving it, or is it the fact that you're then holding onto those carbohydrates differently, creating different types of fat, and then that's driving the cycle?
And it's interesting, the initial inflammation that people are unaware of actually goes pretty well in check and for a long period of time in most people. The people who have the issue are those who have added inflammatory insult, whether it's sedentary lifestyle, poor life choices, not looking at AHA simple sevens, and then compounded by that, they ignore their primary inflammatory disease. So this is not just about psoriasis and psoriatic arthritis, but a whole host of diseases that we have to treat as physicians because it's unethical not to. So we have to treat rheumatoid arthritis. It destroys the joints. We have to treat inflammatory bowel disease. But psoriasis leaves a very open discussion with the patient on what they want to treat, how they want to treat it, and whether or not they want to treat it. We, in fact, had 30 or 40% of our severe population take at least a year before they started therapy. It's unheard of in other inflammatory diseases. And so that allows us this initial inflammatory assessment of the drive of what's going to happen. And then look, if it's genetically driven, it is something that can't be ignored, and you really do have to do something about that amount of inflammation that you're seeing.
So let's talk a little bit more about what's happening now on the level of the coronary arteries.
So I think the biggest question that we need to first talk about is when people bring up cardiovascular disease and MACE plus, that we're all on the same page. So when we're going to talk about cardiac disease, vascular disease, and then cardiovascular disease, Tom, you bring up maybe four big topics that I think are very important to keep in mind for not only healthcare providers, but also patients. You brought up the coronary arteries, which is kind of like the plumbing. The walls, which would be the myocardium, are also at risk in this disease state. The electricity is also at risk. There's more AFib and there's more electrical abnormalities in these patients. They have a lot of PACs. And then finally, you brought up the pericardium that can be highly inflamed in these patients. And what's going on in each of these beds of tissue in the heart or the vascular system is that the chronic inflammation is denuding in some cases for the coronaries and the vasculature, or in heart failure, we really don't quite understand what it is about chronic inflammation. We've shown time and time again diastolic dysfunction in those with active psoriasis. We've shown hypertensive disease in those with psoriasis. So could this all just be blood pressure, right? Number three, when you look at the risk factors for vascular disease, those themselves are upregulated in psoriasis. So there's more diabetes, there's more tobacco use, there's more family history, there's more hyperlipidemia. So you're already in a population that's going to get disease in the vascular system. In terms of what's going on in the coronary arteries, we have dissected that over a 10-year cohort study, and we have a pretty good idea. The coronary inflammation that's detected by PFI, or the vascular inflammation that's in the coronaries, that is not luminal disease, right? That is actually in the wall. There's a change in the edema in the wall. So we've shown that even anybody walking in with severe psoriasis in their 40s has elevated coronary inflammation, which responds to biologic therapy. If you track a person, we said we had about 30% who did not start for a year any biologic therapy. So if you track them for a year, about half of the people who have elevated coronary PFI will then develop a coronary plaque. And it usually starts as a small, shaggy, non-calcified plaque, lipid, maybe a little bit of high-risk features to it. And then we had a group of people who still didn't take any treatment from years 1 to 4. And by 4 years, all of those who had elevated PFI and a plaque progressed, all of them. And all of them progressed into a lipid-rich necrotic core containing high-risk plaque coronary artery. And one person actually had a myocardial infarction. So if you look at that, that is without fail telling you that the coronary develops over time, coronary inflammation, non-calcified plaque. And notice I have yet to even bring up dense calcified plaque, or CAC. CAC in this population is going to underestimate and miss disease. They tend not to calcify their disease because they're so young. And so I think the coronaries are easy to follow. The myocardium, I think if you look at the amount of patients, about 55% of all my patients walking into a clinical trial, 1 in 2, Tom, will not know that they have high blood pressure. So could that be the diastolic dysfunction you're seeing that's leading to heart failure and myocardial disease? Possibly. And then finally, in terms of what we do about these things is education, awareness, and screen for risk factors, right? So if you actually treat their disease, screen for risk factors, I think that the patients can actually live normal and long, healthy lives. It's just a matter of actually making the diagnosis, and how to do that is not clear.
Getting to the diagnosis, I think, is going to be part of the problem. One of the things that we just saw in, of the SELECT trial, where they were looking at changes in ventricular function and that they saw improvement in diastolic dysfunction, which they think was an inflammatory response. In coronary disease, it's quite different what we're looking at. And I think that when you had talked about CAC scoring, and I think that CAC scoring is super helpful for large populations. But on the individual level, on the more granular level, I do think that we're missing things. And we're definitely missing things in earlier patients. When they looked at the orphan trial, there was about 45% of them that had low risk findings on their plaque analysis, but who had elevated inflammation, and they still had increased cardiovascular risk. So we're clearly missing things if we wait until they develop enough plaque and that they have enough response that they develop calcification. So a big question for us about how to identify those patients earlier. Should we be doing more carotid IMTs, or should we just be looking at coronary inflammation using CTAs and potentially doing some type of PVAT analysis?
So, Tom, the first thing is I'd like the healthcare providers and people who do treat these patients to remember that the guidelines don't do a great job here, but you should still use the guidelines. So looking for risk factors and then treating age appropriately, that's said and done. Beyond that, identification of patients earlier. This is a time when I use markers in the blood in conjunction with some imaging-based markers to make the case for the patient for early statin initiation. Remember, our guidelines actually have our backs here. 2018, very proud moment for my lab. We were able to get the ACC-AHA guidelines saying if you have psoriasis, it warrants early statin initiation. Discussions, great. The discussion itself, though, is only a discussion, Tom. You need to show them the value and the worth of the other things. And so the two things I use, I'm not somebody who's selling images, so I'm not telling people to go and image away. But if you have the ability and access to get an IMT, that's great, because an elevated IMT would also tell the patient they have early features of vascular disease. I didn't say no to getting a CAC. I would just avoid doing it, a coronary calcium score, coronary artery calcium score, but I would avoid getting it as the only way of making the assessment, because if it's 0, and you withhold a statin, I believe you've actually done this patient disservice. So I use the CAC as a different tool, and I can talk to you about that later. If everybody in the country could get a single luminography CTA that then gets assessed for P5 or coronary inflammation, I think, of course, we know that that works very well in the research world, but it may not very well be practical. So what do I recommend is usually for the diagnostics, 3Bs, blood pressure, body mass index, and get blood, the blood for lipids and glucose. And the body mass index should be less than obese, and the blood pressure should be normal. Those three, coupled with a consultation with a physician or a healthcare provider, looking at those labs, keeping one's psoriasis under control, there's really not much else we can do except then start looking at blood biomarkers. So there are a few markers that we have used over a 10-year period that showed when elevated at baseline and unaddressed, coronary disease ensues. When elevated at baseline and unaddressed, you may have more worsening response to biologics and psoriasis. And then a third one, which is an inflammatory marker, which when elevated suggests, persistent elevation suggests that you have vascular disease. So we could use blood biomarkers or blood markers to make some of these assessments as well. But my sense of what I tell patients is we're just chasing things. I don't recommend getting tests in the blood just to look for things. If they're asymptomatic and you're looking for screening, the guidelines will say, in order to prevent the disease, look for risk factors, keep their disease under control. And if they have the ability to get an image of something that shows they have vascular disease to keep them compelled on staying on lipid-lowering therapy, you should. But most of my derms and most of my rooms are now feeling comfortable even recommending starting statins, 10, 20 milligrams, right? So there's something to be said about, do you need the imaging? If you can get it, it may help the patient stay on the drug.
One of the general issues that we see in clinical cardiology is people coming in looking for the risk assessment, but mainly because, for example, they have a family history. And so in a little bit, you're shooting in the dark here, trying to figure out, well, what was their family history? You have a younger person who has a coronary calcium score of 0 because their doctor got one for them before they got to the office. And they said, well, does this make me at low risk? And clearly, as you're indicating, it doesn't necessarily indicate low risk. It really, in those situations, it really is only going to help you if they're high risk. But when you're looking at inflammatory markers, are there other ones that you are looking at other than HSCRP? And one of the reasons why I ask that is that we know that HSCRP and the coronary inflammation, although they're related, as far as P5 is concerned, they're not one-to-one. We have a number of patients who have low HSCRPs and high coronary inflammation. And then we have a number of patients who have the opposite. So the question is the sensitivity and the specificity of the inflammatory markers and how this is going to help you a little bit in talking to your patients. And part of this is for now, and part of it is where do you think this is going to go as far as markers are concerned over the next 5 or 10 years?
Very little reason, in my opinion, to look for an inflammatory marker in a patient that you know has chronic inflammatory disease. So the HSCRP, if it's low, you're not going to believe it because they have an inflammatory disease. If it's high, you're going to believe it and think it's from the inflammatory disease. But nowhere in there do I use it for cardiovascular risk stratification. And the reason is that in states of chronic inflammation, it's hard to track a CRP with disease activity and sort of separate them. But in terms of other markers, so I brought up 3 earlier ones that I kind of alluded to, and I'll give them the names now. But the first marker that I really do think is clinically actionable is the neutrophil lymphocyte ratio. So you have an NLR, and it basically shows you have a tremendous amount of myeloid inflammation in the blood. We've shown NLR with Paul Ritger's group to be associated with MI, second MI, post-MACE MI, post-stent MI. You could just keep going down the line. It was 6 contemporary cardiovascular trials. Then a second study we did, we looked at NLR with non-calcified coronary burden, and we found a very tight relationship that the higher the NLR over a cut point gave you that sense. And then third, we've also shown that the NLR responds to biologic therapy and parallels the skin. So we do believe it's a good marker for tracking systemic inflammation following biologic therapy. After NLR, I also very much, and that's clinically available on a CBC with DIF, neutrophil lymphocytes make a ratio. The second one is only available through LabCorp, or it's a test called LipoSciences NMR spectroscopy. And I do track glyc-A over time. So glyc-A is a glycan marker of acute phase reactants that's measured by NMR spec. You can get an LDL particle size and number in that, sort of exact test. But why I like glyc-A for markers of inflammation beyond CRP is we've done the test. In psoriasis, glyc-A predicts disease outcome for CVD, psoriasis, NCB, lipid-rich necrotic core better than CRP. We don't like to pit things against each other. CRP still provided incremental value beyond risk factors, but our glyc-A marker was a bit stronger. Finally, I don't measure insulin in the clinic, but I do try to calculate how insulin resistant someone may be. So I use their body mass index, insulin resistance, maybe a waist to hip ratio to look at overall cardiometabolic disease activity. And that helps me with inflammatory markers. So we used to actually, when we get the glyc-A, there's also an LPIR score, and it would tell you how insulin resistant someone is based on their triglyceride to glucose ratio. We had done one last paper where we did a triglyceride index. It was called the TGI, triglyceride glucose index. That's yet another way of finding insulin resistance. So if you have clinical markers in the blood measured, you can do those three, or at least two of them pretty simply, because most people have a triglyceride and a glucose. The NMR spec, I don't recommend getting checked unless you have a concern of your cardiovascular history, or you happen to be getting blood drawn and the test can be sent out. But it goes under the LDL particle number.
So on to therapies. We have a recent paper that was published, I guess it was at TCT, where they're on colchicine. Clear Oasis 6 showed that colchicine didn't work. After Ledoco 2, Colcat all showed some improvement with colchicine. I guess the next question is, why do you think it didn't work? And what do you think is involved here in trying to find a therapy that does work for treating inflammation in cardiovascular disease?
The why it didn't work, Tom, is very hard to answer after we saw Colcat and Ledoco in the patient populations, which were similar. I'd have to dig deeper in and understand whether there was some difference in the patient population tested in some way that may have precluded a positive trial. Regardless, I do believe that the Ledoco and Colcat trials taught me that treating in the right patient population, maybe it's the frequent flyer to the cath lab, the veteran who's had 17 stents, maybe it's the person who needs the fire put out. I think that the therapies, colchicine offers a very effective way of testing that hypothesis. I don't think that this trial is going to change any of the practicing behaviors of colchicine, which were nil anyway in this country. I don't know how many, partners of mine.
I was a fairly big user. I wouldn't say it was above 5%, but I was certainly used it in patients who I was noticing had chronic inflammation. Now I'm uncertain. I did look at some of the early results from Clear and also from the other ones. I was surprised that in Colcat, the ones who seemed to get the greatest benefit were the ones who were early, who were started early. And all of the patients in Clear were started early. And so I had originally thought that Clear wasn't positive because they were going to not be treating the patients who had chronic inflammatory issues and that they were treating all comers. But that's what Colcat sort of treated. And so it really does bring up a lot of questions. It did seem, though, that the patients who had the greatest CRP drops seemed to get the greatest benefit. And we've seen that in a number of different trials. And we saw that, for example, in your oxidized LDL study, and we'll get to that in a second. So I'm wondering whether part of the question on how we're treating this is that we just can't treat all the patients the same, and that what we were talking about by systems diseases, and that we have to really look at the processes that are causing them, maybe part of that issue.
Really brings up the idea of personalized medicine, Tom, in the sense that, we, towards the end of my 10-year cohort, we asked the question, well, let's label people whether they're high IL-17s or high IL-6s or high IL-18s, right? And what we found was it was very hard because there's so much collinearity of these with other things. So what you're actually saying was the high 17s were the ones with uncontrolled psoriasis and high PASI scores, right? So I'm not sure the next route, but I do know that personalized medicine could be as specific as what we just discussed, which is you tailor the therapy based on what you see in the blood rather than just by guidelines and cookbook medicine. You look for evoked or response testing. If they respond to something, you know that that's going to be something along the pathway you could use. But I think you're right. A little bit more data is going to be necessary in terms of understanding, are there the right folks for colchicine, right?
We've also looked at different other immunologic agents. Methotrexate was studied. I think that there's a lot of question about the trial, how it was done, because it was low-dose methotrexate. It did not decrease CRPs in the trial. So maybe we were missing an opportunity there. Canakinumab did demonstrate benefit, but with a significant off-target effect of increasing sepsis, although an interesting also off-target effect that it decreased different forms of cancer, so now being studied as a chemotherapy agent. We have three studies that are ongoing right now for ziltivekimab with Paul Ridker's group. We were involved with Hermes, there's Zeus, and I think it was Artemis, is the third one? Mm-hmm. So I think all of those three are going to really move the needle forward on how we understand use of anti-inflammatory agents, although each of these is very different, right? The action of colchicine is extremely different than the action of methotrexate, which is extremely different from these specific IL-6 blockers.
Right. Absolutely. It's a great point, Tom.
Are there any other kinds of therapies that you've been looking into? You had a very, very nice paper that I think you put out in 2022 on CETP inhibitors. Otesetromab, I'm getting that wrong, I'm sure, is being studied in a trial of the sixth CETP inhibitor. But your discussion on the CETP inhibitors was very interesting on the inflammatory response that it helps to block and the potentials of decreasing a number of different disease states outside of cardiovascular disease, but specifically with diabetes and maybe neurologic diseases. Do you want to go over that just a little bit?
Yeah, I mean, for other kinds of therapies, it's interesting you bring this up. I think that you nailed it. Anti-IL-6s, anti-IL-1 betas, and the CERT study with methotrexate gave us an idea that there are three tenable options that we can test, and each one of them is going to be very informative in its own ways. In terms of the CETP inhibitors, it's interesting you bring up obicetrapib in the sense that they're using it very creatively. The CETPs really failed in what they were hopeful for, which was cardiovascular outcome trials related to HDL raising. And what we learned from those trials was that they had a steep reduction in LDL for those patients who were on the drug long enough. And so I think that for an inflammatory population, hard to see what's going to happen with the CETP inhibitors in terms of whether they're going to find any mainstay or whether they're going to have any great benefit in those. I can see them being off-target beneficial in inflammatory disease states in terms of what they're going to do to HDL function. I do think that there is this idea that there are new anti-inflammatories down the pike. And I think what I'm most excited about, Tom, is actually the oral IL-23 inhibitors. The fact that there are oral medicines that can be made in a way that allows us to not have monthly or weekly injectable dosing. So for me, I think the future of this is going to be continuing to curb 70 or 80% of the model's risk for having another event. And that last 20 to 25% that we're treating with inflammation, or treating inflammation for, I should say, I think is going to actually take on a few different strategies. There'll be an anti-inflammatory, but then there's also going to be an appreciation for optimizing the person's weight. I do think that we have ignored the fact that we're in the Ozempic revolution and nobody's really thinking about what that's going to do in terms of weight loss in inflammatory diseases. And then third, I think the last kind of therapy that I'm most excited by is progressively better biologics in psoriasis. Think about that. We're at PASI 100s within 3 weeks of starting an IL-23 inhibitor like bimekizumab. So I think that's what I'm most excited about, is seeing those drugs move their way into cardiology.
My take on all of this is that we have to be very careful on how we're going to be looking at these drugs and making sure that we're really focusing on the right patients for therapy.
That's right.
I've been a strong advocate for utilizing some other forms of indication of who we're going to be involving in these trials so that we get patients who are at very high risk so that we can see events, and B, so that we're getting patients who we can follow something to see whether or not we have early response. That's one of the reasons why I like Matt Budoff's work that he was doing in Reprieve, for example. They published that result showing that in the short term on Reprieve, they had plaque stabilization that they could already identify. I know that that group is going to be looking at perivascular adipose tissue imaging. I'm not sure that they're using the exact right marker for doing that, but I think that they're going to get some good information on early decrease in inflammatory response for that. But also they've indicated in both of those is that they had an increased inflammatory response at the beginning. So before we give these patients these drugs for the entire cohort, we really have to start looking at, okay, are these patients going to be the ones who are likely to respond? And then we can then see the response. That dovetails nicely into your antioxidized LDL trial that you did, that you released at the ACC this past year. Why don't you walk us through that? Because I thought it was extremely interesting, both on a diagnostics follow-up side and also on the therapeutic piece.
Yeah, so it was an interesting study run by Abcentra. It's a MD 100 ApoB modified antibody. So it's your oxidized ApoB moiety, and it targets it directly. So it targets it in the tissue. The hypothesis was use of the drug over a 4-month window, and there were co-primary exploratory endpoints, would improve PFI as well as improve psoriatic features. And 30% decrease in psoriasis at the peak, which is, not bad for an adjunct or a topical, sort of medicine, not a primary biologic. But what we found was very interesting. So first of all, very large cardiometabolically challenged population, 75 people. Their average body mass index was in the 35 to 38 range. A lot of latent coronary disease that we didn't know about, all asymptomatic, about 25% plaque prevalence. And then we found that those who had high PFI at baseline responded beautifully to the drug in a statistically significant manner in reducing PFI in all three vessels. However, when you looked at the entire group, if you did not have an elevated PFI, you actually didn't have anything to move in the coronary, so we didn't see anything there. It was safe, it was tolerated. And I think the most important lesson of the trial was using tissue-based or tissue-specific measures such as PFI on a tissue-based antibody like Abcentra's orticumab. I do think that you could get a really nice future now CVOT trial or some sort of a trial where this is what the next step is in this drug development path.
Enrichment in that way, I think, is going to be helpful. And ultimately, I think that it's going to be helpful in the way that we're going to be focusing on our other therapies for patients just in general.
Yeah, totally, Tom.
When I'm going through clinic and we talk about our outcomes questions that we look at, and my patients always ask me, so how am I doing? And the answer is, well, when you turn 90, I'll let you know. If you don't turn 90, then we failed. And if you do make it to 90, then we've been successful. And I don't think that that's really something that we can stomach very easily and just saying, yeah, we got your LDL down and we'll see you next year.
Right.
So being able to follow something up more closely, I think is going to be very helpful. And that's why I'm excited about the results from your trial, because that did show that PFI was something that was modifiable. It was a good question on whether or not it was sort of tattooed into the adipocyte, that those changes were made, and then you wouldn't see the differentiation over time. But we can. I think that the Reprieve trial, if that comes back demonstrating that their version of PFI, that it decreases with the treatment with ativastatin, then that will let us know whether or not we've been successful with statin therapy, for example.
That's exactly right.
And maybe we don't have to go beyond statin therapy. We've been very involved in the lipoprotein A trials, and I'm very proud of our team. Right now, we're the national lead for recruitment for Acclaim. And so we're extremely excited about this. But, you sort of wonder whether, A, if you get their LDLs down to extremely, extremely low levels, does that then decrease the amount of inflammation that they're going to be having in their vasculature, which will then decrease the prevalence of events and such that you don't need to treat their LPA, which would be great, not having to spend $10,000 a year on a drug when statins and ezetimibe can do. Or do you have to treat all of them, which would be fine too. If once you know the answer, then we can tailor our drugs to that answer. And maybe it's just that when patients have coronary disease and is stable, that they don't need a lot of these things. It's a very interesting question of which you've really been on the forefront of trying to figure out how to make those diagnoses and then how to deliver those drugs. So I did want to get, while we have an opportunity to talk a little bit about, you had mentioned some more of your recent research that you're doing with retinal arteries, which I love as a model because that's one of the few arteries that we can actually see and evaluate, and looking at the cholesterol deposition and fat deposition there, and potentially how that is going to be a model for how we might be able to evaluate other vascular disease states.
So it's great that we have the opportunity to think about that. You brought up early on that this idea of the system, right? This idea of accessing the systems-based process. What we appreciated over time by the 14th, sort of observation year of the cohort was that lipid accumulation over time in the vasculature led to non-calcified burden, and the carotids led to stroke, both of which were upregulated. In the skin, more psoriasis flares, which we saw. We appreciated fat in the bone marrow, and it was inflaming the bone marrow, probably why we're seeing more cancers in these patients and other, sort of bone marrow failures. But along the way, I started thinking about where else would you see this metastatic lipid deposition or accumulation when it's everywhere. And one of the areas that I got very interested in was neurons and the optic nerve. And it's actually part of the retina brain barrier. And I learned that the retina actually does collect cholesterol and lipid over time, and it does oxidize. And there's a lot of stuff that happens that's very similar to coronary disease. So I've taken it upon myself to figure out what that lipid accumulation does. And there's a good amount of literature on that. It causes vision loss, causes holes in the eye in the form of geographic atrophy. But I've also taken time now to figure out how we can remove that lipid. And there is a way you can actually go in there and, figure out what the pathogenic lipid is. And I think what I'm most excited about over the next 10 years is the continued appreciation across multiple disciplines that lipid accumulation drives several processes that are associated with diseases of aging. So now we have blindness, atherosclerosis, or myocardial infarction. And then you think about the other ones that people are most after. They have without fail shown a role of cholesterol handling or mishandling in their inception. In fact, some of the chronic diseases of the CNS are now thought to be due to lipid accumulation. And so I think we're in a very exciting time to make therapies to actually address those.
One of the questions I have on that very specific issue is our decreased ability to actually change lipids within the CNS. Most of our drugs do not cross the blood-brain barrier. So our ability to sort of address that systemically is somewhat limited. I've always been careful to talk about my patients about when they say that it causes them to have fogginess or decreased mental status, and the trials did not seem to support that. But on the flip side, I do agree with you that there's something else happening here with cholesterol management and with lipid management in the CNS that is part of that process. And maybe it is, that's a chicken egg question with inflammation itself. What are your thoughts on how that is being driven, since it is a different blood pool of cholesterol?
That's a hard one. That's going to take some time to reconcile and understand, because the cholesterol in the eye actually does not move from the body to the eye and back. Actually, it is cells that are turning over at the most rapid rate in the body, and that cholesterol that's coming from those cells is actually what's being accumulated. When you have cardiovascular risk factors, you have a weakened vascular system, choroid, all of those things. That ends up driving the process. There's some genetic mutations, and they happen to be in the pathways of, funny enough, CETP and HDL metabolism that suggest that people who have constipated metabolism of cholesterol, it's happening everywhere. And so I guess my sense is that we're going to do well if we can find a drug that does cross the blood-brain barrier and can address this directly. Until then, I would remind patients that even having less bioavailable cholesterol in the blood pool will help this, because if it's lower than what's in the choroid, it'll passively transport in there, right? So I do try to tell my patients that, yes, you have dry AMD, it's lipid driven, and it will help that you treat your cardiovascular risk factors and also see your eye doctor.
It does really all come back to, if we can start treating the risk factors that we already know, we'll be a lot further ahead of the game than if we just wait until we're trying to treat the disease. Every conversation starts with, we need to improve your diet. We need to improve your exercise. Can you please do those things? Because we know those help regardless.
Right.
And it helps people with CNS disease as much as it helps people with coronary artery disease. I have a feeling that it probably helps in rheumatologic diseases as well.
Absolutely. I would just like to close by saying thanks for shedding light on this. I've been doing 20-something years of work in both preventive and general cardiology, and it makes me very happy that these discussions are now becoming dinner table discussions and now scientific discussions that really do mean that we can tackle this epidemic of inflammation and heart disease, but we need systematic ways to do it. I think the advent of what we started as cardio-rheumatology clinics is one way to do it. Another way to do it is to just get it out there to the patients and do more of these types of communications. So I really appreciate you spotlighting the importance of this.
Well, thanks again. I am very excited again to be working with you on other issues with inflammation. One of these days, I may have you come back on and we'll talk more about HDL cholesterol, because I think that's going to be another, really ripe area of research and understanding. And we will be speaking again soon. Thanks again.
Thanks for having me, Tom.
Thank you for listening to Future Pulse. If you have any questions or comments, please feel free to email us at the link below. If you enjoyed the podcast, please rate us, as it will help other people find the podcast. Finally, if you found this podcast interesting and you wanted to share some of the ideas with your patients, you can refer them to Patient Pulse, where an abbreviated version of this podcast will be posted. It will be more patient-oriented, so they may enjoy listening to this information.